So we switch now to New Delhi to Dr. Balbir Singh. Welcome. You are online now.
Balbir, can you hear us?
Hello, can you hear me now?
Yes.
Okay, so welcome to this meeting and welcome to this live case. We have a very challenging and a very difficult case here. I'm with Dr. Rathi, my colleague, good friend. Then we have Dr. Brijesh, we have Dr. Amin, Manjeet, and the technical team, and we have the nursing team, Shivani and Vishali. So we doing this case and we'll just present you. Can you show the PowerPoint slides? So this is a gentleman who is 61 years, non-diabetic, very long history of coronary artery disease. His brother died at the age of 46. And this gentleman underwent a stent in 1997 at a very young age. So you can imagine at 36, he gets a stent. And at 97, he got a stent to LAD. And this was a non-drug bare metal stent. And since he was doing well. So 97 to 2017, he did well. And then he had a stent. Do you see the PowerPoint slides?
Yes, we are seeing.
Okay, so then he had a stent in 2017 to the LAD, to the LCX and RCA. So we'll show you the 2017 stenting because this will have some implications of his present problem because he's come back with serious problems within 6 years. I got the CD from the institute where he had got it done. We'll show you that CD, 2017 ka. So this is the angiogram of 2017. You see an LCX disease. The osteum.
Please put the angiogram. You're not seeing
angio is not seen.
Next slide.
Angio dikha dijiye.
Yes, we can see it.
Okay, so this is 2017 because this is very important angiogram because it gives you a lot of idea how disease can progress. The ostium of LCX seems to be spared. There is a lesion in the proximal part of circumflex, which is significant, and the stent has some borderline stenosis. Next, which the team thought was not significant. Next, please. Next. So this is the LED, which does not seem to be significant.
Slides are stuck.
We don't see.
Move नहीं हो रहा यहाँ. यहाँ move नहीं हो रहा. नीचे यार उसको बुलाना ये कह रहा stuck है वहाँ. So I'll show you the slides.
Is there any other view for the LED?
Yeah, we have all the views. So I want to show you because this has all the implications for today's problem. And today's problem is very nasty.
Well, you can tell us because I don't want to waste.
LED, so now the LED was, can you see it now? No. You don't see. Okay, LED had mild instant restenosis. It was thought, let's leave it. They went with the circumflex stent and the RCA stent. So RCA was stented. The circ had a stent, but they found that the ostium didn't look nice. And they tried to put a stent from the ostium of the circumflex to the.
This is now the current angio from today.
I will show you today. So they put a stent into the circumflex ostium, trying to spare the LED without a kissing in the left main. And he came back within 5 years with severe symptoms. The symptoms have been there for 6 months. So we'll show you the today's angiogram now.
This is old picture what we see here.
Now you see the today's picture.
Today.
You see that?
Yes.
So there is a stent in the circumflex. We are not sure whether it has come to the ostium, whether the part is in the left main. We are not certain on that. There is a very tight left main stenosis. Next picture. This is the epicranial view. So there is a clear in-stent restenosis of the bare metal stent, also involving the proximal part of LAD. And distal to the stent, there is disease. Next. And you see a very tight left main. So we wired the LED, and then this was a very difficult wiring. So 3 different wires actually have been tried. And ultimately, this is a whisper wire which went in. and a lot of difficulty. So clearly indicating to us that there was some issues of the stent struts into the left main. So the implications are that if you are going for an osteal disease stenting, you have to be very sure. Now you have disease in the proximal part of LAD, which wasn't there earlier. Nothing was there in the proximal part of the LAD. You have disease in the left main. And I believe that this is because of the osteal circumflex stent, where stent struts must have been protruding. No kissing was done. No attempt was made to do even a provisional stent to the ostium of circumflex to the left main. So this is trying to do a perfect osteal stenting has its limitations. So we were able to cross next. Now it was the imaging. So we had both IVUS and OCT, because this is the topic today's discussion. So I thought let's first dilate this lesion with a balloon, because the flow in the LAD was coming down, and clearly I had to make a passage for it to. So I took a 3O balloon. Next.
Did you cross the LCX osteum?
No, I have not attempted to cross. I just wanted to make a passage to give him flow and relieve some of his symptoms of angina, which had started coming. You can see clearly with just the wires in, there is flow which is reduced both to the circumflex and the LAD. So we went ahead and dilated this with a balloon to make things better for him and make us more comfortable doing imaging, because with the imaging catheter, we would have crashed. Next. After this dilatation, next. You see this is OCT catheter in. There was a dissection. We knew even before putting the catheter, there was a dissection in the LAD ostium and the left main. Clearly is visible with just a 3 millimeter balloon at 4 atmospheres pressure, indicating how vulnerable this plaque is. And this is one OCT and then an IVUS. Both images have been done. We'll go straight to the imaging part before we go on to the discussion. Can we have the OCT first? So this is the OCT. You can see I have not put the catheter deep in. I have done that later to assess the deep depth of it. This is in the LAD proximal part. You see a dense neointimal hyperplasia, atherosclerosis. As we come proximally, this is the stent which is also underexpanded. And we come to the proximal part of the LAD, which is quite big, about 3.5 to 3.6. And then we come to the left main. You see the dissection flap. You see a protruding calcium. And then this is the left main, very tight stenosis. And we come to the proximal part of the LAD. And then we did the IVUS. I'll show you the IVUS now. So comparing...
Why did you do both? Why did you do both?
So this is Dr. Srinivas. I'm thankful to him for allowing me to present this case, but he wanted me to compare IVUS versus OCT for left main. So my preference generally is OCT, but he wanted me to the audience show the comparison, how they appear and what are the benefits of one over the other. Can you show the IVUS runs?
Yeah, we see already IVUS.
So
running.
I have taken from the distal part. So there is disease in the distal part. Can we show the first? Can you go back and show the first measurement? So this is the measurements on the normal part of the vessel, which is around 3. So this is the distal part of the LAD, around 3. Now we can run. So we come to the plaque. You can see we are in the plaque now. And there is some calcium, not much. So we'll be able to handle this with an NC balloon. Just as we go proximally,
between the patient was stable, right?
so immediately after this, we saw the QRS broadening. Fortunately, no hypertension, marked ST elevation. So we had to quickly stent the left main. So you're right, imaging can take a toll. So doing 2 imaging, his ST rose up significantly. And we had to quickly stent the left main, which we'll show you.
Did you, are you telling us that right at the left main, at the very end of the IVUS run, we felt, at least they got the impression that there was almost a 360 calcific segment that probably is just proximal to where your dissection in the left main is in the LAD. So I don't know, are you also interpreting that image similarly, or am I not correctly
No,
seeing?
I would show you the OCT. There's a calcified nodule. Again, we saw calcium, but it is not. You see this calcium in the distal part of the left main. Can you go to that? It's it's an arc on one side. This arc is a calcified nodule on OCT. So we are comparing a black and white movie with a colored movie. So we go back to the OCT and I'll show you the calcified nodule at that part where we had the dissection. Can you show us the nodule?
A little bit more proximal is what I was looking at.
Oh, go proximally a little bit on IVUS. IVUS में थोड़ा सा proximal जाना.
It's okay, no problem. Show us the
we'll
OCT.
We'll show you. We'll show you. So this is the calcium and probably a calcified nodule, but we'll not sure. There's calcium on one arc, even the proximal. It's not 360 degree, which is was very certain on.
If you go a bit back, there was some more calcified
back.
segment.
Go back, go proximally. Yeah, go back, go back, go back, go back. Yeah, this is the calcium I have. No 360 degree.
No, in ostial LAD, I think.
Ostial LAD pe jao. This is the LAD. We go forwards now. Yeah, this is the ostial LAD. This is the proximal LAD. We go to the ostium. Go back. Go forwards now. Go forwards. Go to the left main. This is you're going backwards. Go to the left main. Go forwards. Go forwards. Go forwards. Forwards. Okay. See that this is the left main. So there's no 360 degree arc. Now we show you the OCT. Go to the OCT now.
I also could not find any 360. I just find nodule.
आगे जाओ, मुझे left main के पास जाओ, जहाँ nodule है वहाँ दिखाओ. So you see this nodule protruding into the left main. Go forwards. This is the nodule.
Yeah, very, very clear. Thank you.
And we have already created a dissection in the nodule. So you can clearly see nodule on one side. The dissection is coming from upwards, downwards, telling you that you created more pressure there. So there's clear dissection with the nodule, right?
Okay, plaques are correct.
So the first lesson from here is that left main bifurcation is better evaluated by OCT. Second, calcified nodule is better seen. Third, a dissection can be so clearly seen on OCT and not so well seen on IVUS. Three glaring differences which I have shown you in this. This calcified nodule we were imagining on IVUS is clear on OCT. The dissection not so sure on OCT. IVUS 100% sure on angio and OCT. The dimensions are reasonably same. The 0.2 less on OCT compared to IVUS. Today's dimensions are almost same except 0.2 less. So this is the challenging case that we are doing. I think it's one of the most challenging cases because not only we are dealing with ISR, we are dealing with distal disease, we are dealing with a calcified nodule in the left main, we are dealing with a circumflex which has been stented 5 years back with some definitely protruding stents into the. Can you show the 3D bifurcation on this?
So how is your strategy now for this case?
So the first strategy was to stent the left main. We knew the patient was, the QRS had broadened significantly. There was marked ST elevation, and we had to quickly stent the left main. So the strategy was first to stent the left main. My strategy is provisional, then go to the distal part of the LAD and the ISR and tackle both of that. So we'll show you the next picture on IVUS. So this is the 3D bifurcation view. You can see the stent of the circumflex right up to the ostium, and we have actually crushed it with the first balloon that we did. Next.
So did you do a run from circumflex also?
No, not yet. I know I have to salvage this patient first. All that is academic. We'll come back to that when we have time and save the patient first. Doing a circumflex run without tackling the LAD and the left main would have been a disaster. So
Yeah,
the first...
we understand you had hemodynamic problems with this patient. That's why you immediately performed stenting from the left main to LAD, right?
Yes, right, exactly. So now we show the stent. Next picture.
I think this is very important for younger doctors, not to lose time to wire or to prodilate circ if there was a huge problem in left main. So please fix first the main vessel. And then, of course, we will have now even more difficulties to cross circ, but don't forget, nowadays we have excellent wires with angulated microcatheteres. So I am quite 100% sure we will be able to recross the LCX to perform at least perform kissing, maybe t-stenting.
So I had the dimensions on IVUS of the left main as 4.5 and 4.0 on OCT, 4.1 on OCT. And the proximal LED on IVUS was 4 and 3.65 on OCT. So I took a 423 stent and deployed at 8 atmospheres. My reason for taking a 4 stent was that I would create an apposition in the left main. I would be able to easily cross the circumflex if there's a problem, rather than having to go with a pot balloon again. And my decision to take it at 8 atmospheres was based on the fact that I will not be nominal on the LED, so I will be able to.
Which stent did
I took a Zions. It's a Zions Alpine.
Science.
So you can see at the distal part of the left main, there is under expansion of the stent. Obviously, I had gone on the low atmospheres. So
if you ask me, I think I personally would choose here Onyx stent, because it's the easiest way to recross through the struts. However, you are a very experienced operator, so you will also be able to recross. But I definitely final pre-pot proximal optimization is now needed.
Okay, so next. So I recrossed at that stage, even before pot. I thought my proximal part of the stent is well placed, well opposed. So I took a wire. This is the whisper wire again. And you can see mild difficulties, but able to recross quite easily. So we removed the previous wire. So I had the previous wire also left in at that place and removed the previous wire, went for a pot at this stage. Next. This is the pot with a 4O balloon at 20 atmospheres. Next. And after the pot, we have taken OCT. Can you run that? This OCT is to check if my proximal stent is well opposed, and also to check the wire position where I have crossed this circumflex. You can see the 3D bifurcation view. All this cannot be seen on IVUS, so you can't see where the wire crossed. This is a 3D bifurcation view on OCT. You see a proximal cross of the stent. Is it clear?
Yeah.
Okay, now we give you dimensions on this stent. Can you go back to the, yeah. So now we see the well-opposed stent in the left main and very well expanded in the LED. We try to see where the calcified nodule is and what is the area at that point. So this is the area around 8 point something. I can see 8.34 at that particular place, but it is roundly, you can see it is round. It is not a D-shaped engagement. And I'm going to do a final plot with a 4.5 balloon when I end the procedure, which is also what I have decided, that after doing distal LED, after optimizing this pot, do a kissing balloon and then a final pot. So this is what we have decided to do. This is 4.1. So our 4 size was quite okay, but I was suggested 4.5.
Okay, maybe we just let you do now final kissing, and between we go back to Hyderabad to Dr. Kumar.
That was very beautifully demonstrated and an amazing job to take care of the patient, which came first. Excellent. Thank you.
Thank you.
I'll see you later. So we switch now to Dr. Singh.
Balbir, we are back to you. So please tell us what you've done, and then we can keep in touch. Can you hear us?
Where we left. So next. Piche. Okay. So we left you at this point. You see, we have optimized the LED stent. It's much better than what you saw. I showed you the imaging after this optimization. Next.
That distal left main looks so much better now after you've potted it. Yeah.
So now we went to dilate the distal segment of the LED with a score flex balloon. We have measured it on both imaging, which was almost 3. We took a long stent, next 348. So we took a long stent and we have dilated that Now I'm going to go for one more stent, 6, 8, 10, 12, 14. So this is a 3 of 48, which we have already deployed in the distal part of the segment. And we'll need one more to cover up for the in-stent free stenosis and the proximal gap in the LAD. So it will be a complete metal jacket. I know that the other option was to use a long drug-elutic balloon for the distal LAD, but I wasn't too sure about that. The in-stent free stenosis definitely is a neoatherosclerosis, so we need another stent.
Now it looks much, much better, but however, you need now aggressive postulatation with probably 3.5 NC balloon and proximal LAD.
Right, 3.533 stent. So the distal LAD is very nicely opened, and we expected that based on the imaging that we knew that the arc of calcium was less than 270 and the artery was 3. So all that helps.
I think all side branches are nicely perfused at the moment, so that's.
So Dr. Srinivas is there. He wanted a comparison of the two imaging because there has been so much confusion. One says one is better than the other one, and you have a great comparison here already. We will do the final imaging with both the devices to see how they look. And if I get time, I'll show you how to image the left main ostium using OCT. We did do it quite frequently, and we get good images. Next. So we have covered the two stents. Go 12.
Yeah.
12. Down. 3.5 balloon.
I know we had a break in transmission, but I think for the audience, it's important to realize that the wire in the circ that he has now is a wire that he rewired the second time and not a wire that's jailed behind two stent struts.
Right. So I'm going to re-optimize my stent results, then go for the kissing on the left main. And then a final pot, then final imaging with both the techniques.
I think the crossing with the balloon to this LCX will be
A very big challenge.
could be very difficult. So I think.
So what I'm going to do is I'll anchor this balloon and then cross. So first optimize this, let this balloon be there in LED, anchor it, take a small balloon, 2 millimeter balloon.
Yeah, I would suggest to take 1.5 balloon just to open the struts and then take probably 3.0 and see.
1.5.
It's very important to perform final kissing in this setting with NC balloons.
Down.
You have to use pressure around 14, 18 atmospheres.
18.
I love the idea of using the balloon anchor in the LED. That'll help you. That's a great idea.
2 millimeter balloon. 14. Down. Just a test. 2 millimeter balloon. Mini trek, huh?
Yeah, mini track is a low profile balloon. It should work.
Heliocaudal.
There are many options. If you don't cross with 2.0, 1.5, you have also some 1.0 or 0.8 low profile balloons, which are very helpful, and you should have such balloons in your cath lab.
Yeah, we have. So let's hope that this crosses. I'll anchor the heliocaudal. I'll anchor with an LED balloon and then try. LED up 6. LED up 6. 8. 8. Okay. So you were right. It's going to give me a lot of trouble.
Please take 1.0 low profile balloon. Don't push too much. It doesn't make
Yes.
1
sense.
millimeter balloon.
When we are
Yeah.
doing these maneuvers, I think we have to also take care of the LM stent because there
I
is a
know.
possibility of distortion.
Deformity.
The other option would be to take a microcatheter, which is like a 1.5 balloon, to screw that in there with the, and that'll give you a
Well.
little extra. That's like doing a 1.5 balloon.
ये क्या दे रहे हो? 1 के 1.5. 1.
I don't think the difference in a 1.0 and a 2.0 balloon is that much in profile. I think you might be better off going with a microcatheter.
Okay, so let's first
I
take.
think in smaller balloons, your marker is in the middle, and that's make the difference in crossing. Yeah.
Typically a 20 millimeters, so you wedge it in, so you have at least have 10 millimeters as far as it'll go with the
Yeah.
middle marker.
6 on LED. 8.
Okay, probably there is definitely a problem. I would repeat a pot maneuver,
Yeah.
going over the LCX ostium, point number 1. Then I would take some different
LED down.
wire crossing and see extra support wire, and then repeat this again with 1.0 balloon crossing. Maybe even, as my colleague suggested,
balloon.
good idea will be to
4
take
का balloon then.
micro
Are you
catheter as well. Because if some rotatable micro catheter, you can overcome.
Yeah, like a
overcome.
Corsair or anything like that would go
Exactly.
would go easily.
Yes, yes.
So we are planning to use a report balloon
Yeah, report is very good idea.
and then take another wire, cross the circumflex, and keep those 2 wires and the
Yes.
anchor balloon, and then try.
All
Yes,
good ideas, all excellent. So as long as you have options, that's great. Just
definitely.
keep working through the options, and
Yeah.
one by one, you'll be able to sort this out.
Yeah, in some cases, even to take guiding extension guideliner to go just to the ostium could also help. You have 6 French guiding catheter or 7?
7.
7, very good. Yeah, that makes sense.
4 का एक और balloon then.
4 का and then.
So, but the patient is now stable, so you
Very,
have
very
time.
stable.
Yeah, you have time. Take your time, because this is extremely important. Circus, not so small vessel, so you have to prepare the lesion better.
Okay. The LED is good, so we have to.
Yeah, you
Carefully.
have time, but this is definitely very difficult step.
एक second.
So report, recrossing, if this doesn't work, then probably take guiding extension, microcatheter again, new recrossing. This should work.
So I think once Dr. Singh's able to cross, we'll probably have to run over to Hyderabad, because Dr. Ravi's got something to show us with the laser as well.
Anji. Stent boost.
I think almost done and wants to show us a few things. So
Yeah, so there's so many
you
learning
go to,
points in this
Delhi,
case.
please.
Yeah,
They have not come.
Arya Caudal Vapis.
Arya Caudal.
So we have too many learning experiences in this case. We'll share everything with you.
Tell us how you solve your problem, Dr.
I'll
Singh.
show you. I'll show you 1 second. Just give me 1 second. I'm putting a second stent. 12. 14. Down. Okay. So we go back to where we left you. Very interesting. So we left you at this stage where we go back. Okay. Go forwards. So we left you at this stage. Next. Now you see back. We took a stent boost at this point. Can we show them this? Can we show the stent boost?
So we see you had probably achieved some kind of
So while we were
shortening, stent
so-
shortening in the
yeah,
left.
so
main.
the stent was deformed while we were struggling to get the balloons into the circumflex, and that was preventing us to get the balloon. Even if we were anchored, the wire was through the proximal struts, everything was correct.
And this is
And-
very good case to show that sometimes with anchoring you could provoke such shortening because the guiding is coming.
But
if
he
the-
was quite aggressive with the guide too.
Yeah,
He was
yeah,
banging on
that's
it.
correct.
Yeah, see this now? Can you see it? Can you
Yes,
see the deformed stent?
yes,
Even though the stent uses a Zynes, which has the best radial strength, but when we do such aggressive trying to get in, we
yes.
get into these problems. So, right. So we corrected this with a pot balloon. Next angio. Go back now to the angio. Angio दिखाएंगे, अब इसको छोड़ देंगे. Okay, so we corrected this. Now you can clearly see we are much better off. Next. We got the third wire in. Nahi, back, go back, go back, go back. Okay, we're getting a third wire in, and it was quite easy this time to get the third wire in because we had much bigger space. So this is the next trick for youngsters that try to go into the loop to the LED, then come back. You have much low chance of getting into problems. So you got the third wire in. Next, we pull back the second wire.
That's called reverse wiring.
Next. And you see how this balloon goes. The balloon went like zip, no problems at all. This is a 1.2 balloon. It went very easily. Next. Then a 2.5 balloon, very easy. Next. Next. Then a kissing with a 3.5 and a 2.5. I didn't want to take a bigger balloon, the circumflex. I wanted to avoid another dissection. The vessel is
Yes, I think
2.6.
just to open the struts and
So you see this is 20 atmospheres pressure on the non-compliant balloon, 2.5. Next. Then 20 on the 3.5 and finally a 8 millimeter kissing inflation. You see that? Next.
yes, very good.
Next. And then we had to cover up the proximal part of the left main, so we got another stent. Next. So this is a 4/15 Zynes. We have to avoid circumflex this time. Next. And we have to check the ostium on iliocranial, which is perfect. Next. And we deployed this stent. Next. So now we have to take a picture test. Okay, that looks good. So we have a jailed circumflex fire, which I'll remove. We'll do a final pot and then imaging. Would you agree with that?
Yeah, perfect. It's really very, very challenging case, and you could show us how to manage this perfectly. And I think what we saw now by Angel, final result is perfect.
This looks good to me. I'll
Yeah,
do the
very
final
good.
pot and imaging, and that should be all.
Yeah, perfect.
4 open.
So would you go now with OCT and
OCT.
IVUS or just
OC-
one
OCT only.
only?
Uh,
Yes. I
I'll
think-
be able to see the ostium of circumflex without having to recross it.
Yes, very good. What was your contrast medium dose till now?
So till now, it's about 240. Creatinine is 0.7, so I'm not too worried. So I go up
Yes,
to
yes.
300.
Very good. So you still have to be careful with the ostial
Fix.
struts in the left man. Take care with the guiding catheter.
Okay. Next. Test पहले लेते हैं.
So you have now which balloon size?
So I have 4 balloon. I will go up to 20 atmospheres, that make it 4.2 test, which will be the right size for this LED.
I
Okay.
would suggest maybe we
20.
skip now for a short moment to Dr. Kumar, and we'll back to you after to see final OCT, okay? If you
Okay,
agree.
that's fine.
So maybe we go now back to Hyderabad to
Boost.
Dr. Kumar to see how he approached his ostial RCA in stent
कहाँ
restenosis.
दर्द हो रहा है? कहाँ हो रहा है? अच्छा वो ठीक हो जाएगा. 20. ये भी deform हुआ.
We go now back to the cath lab.
Thank you. Yeah.
And Dr. Balbir Singh is just waiting to show us final result.
So we left you at this point
Please,
where we used
go
the-
to New Delhi.
Yeah, can you see me?
Yes, yes, we can see you.
So this is the fluoro image. We left you at this point. This is the final pot. We have now two stents in the left main, one across the bifurcation and the second one quietly missing the ostium of the circumflex so that we don't have to have 4 layers. So next. So this is the angiographic pictures. Next. And all branches are intact. Next.
Excellent. Yeah.
This is the LED, which is really nice opening. We'll show you the imaging results. Can you play the OCT now? So this is, no, go back, go to the distal part, please. Go, can you see the OCT run? No.
No, just switch to OCT. Yes, we can see.
Okay, now you see the distal part of the vessel. We are in the normal segment. There is, can you run now? There is no dissection. The stent takes a very good shape. There's a step up at the distal point. You can see even in the distal vessel, the MSA is about 4.6. And as we go proximally, there's no under expansion. The worst point was in the LED where 3.5, 18 or 20 was done. So that was about 6.7. Can you stop here? This is the mid portion of LED around 6 MSA. Go to the, go further, go down, go down, go down, go down, go down. And after this, we'll show you the LED. So it's all 6 and 7 now. You see a calcium and the D-shaped stent expansion. This is 8.8. This is proximal and mid part of LED. And as we go further, we get areas of 9 and 10 in the proximal LED. Next, go to the next run. This is the last picture, last OCT run, which shows this some dye clearance is missing. We get better images. This is the better image. And you see a very good expanded stent at this point, and we'll show you the calcified nodule and how the stent expands at that point in time. So you see some calcium causing a D-shaped expansion as we go down. This is a calcified nodule in the near the ostium of LED. You see that nodule, how it bulges out, but the expansion is 14.5, which is really good. So this is the nodule which bulges from 6 o'clock into the LED.
Yes,
This is at the
yes, yes.
bifurcation, and this is exactly what we saw on the pre-images. And we go to the now the left main, go down, go down, go down. We show the circ ostium also, show the 3D bifurcation of circ ostium. And it is nicely open. Please show the 3D bifurcation. Go further down. So this is the circ ostium. You see 2 fenestrations. One is a small branch coming out, and then the circ ostium is clear of any struts, which was the aim of a kissing balloon. Clearly clear of all struts of the left main stent that could possibly be seen. So this is reasonably good. The distal part of the left main with the nodule has a area of about 10 to 11, so we don't bother. Go proximally, we get areas of 14, 15 on the left main, which again is reasonably all right for a good left main result. So this is the final picture. You see good areas as we go down 12.5, and we go up to an area of around 14 also in this 13 point something, 13.5. So reasonably good expansion in the proximal part. There is some calcified nodule causing some bulge on that part, but with the area of around 10, 11, I think I'm quite okay with that.
Yes, okay. Thank you so much for your great case presentation with both modalities of imaging. And finally, we saw very clear
Dr.
benefit
Rathi.
for OCT. Thank you so much.
Any comments from Dr. Rathi is my colleague, so he's been through with me all the difficult steps.
So it was really challenging to recross the circ, and as you know, that we had 3 layers of the stent at the ostium of circ. And the important thing is, if your one wire is not crossing, not taking the balloon properly, always take another wire and try to recross. That's the
Yeah,
crux.
exactly.
All right.
Okay, thank you so much. Great
again.
case.
Thank you.
Thank you.